our country. So 12 hours has gone. We have given IV artesunate, but still the consciousness is impaired. And I tell you one thing, if you give the right drug in malaria, the improvement is very rapid. It starts improving within 3 or 4 hours. But here the 12 hours has gone, but still impaired consciousness. So what do you think has happened, and what test you would like to perform?
CSF examination.
First, CSF examination. Why is it a cerebral malaria? How CSF examination will help?
One is to rule out anything, but we have to be little careful and look for the parasite in CSF,
No.
though the yield is less. I know you may not agree with
No,
it.
I don't agree. The most common complication of cerebral malaria is hypoglycemia.
Hypoglycemia. I know.
You give whatever anti-malarials, you give whatever anticonvulsants. If you don't correct hypoglycemia, the child is never going to improve. So much so, the manifestations of hypoglycemia is almost similar to that of cerebral malaria. They will come again with change in the level of consciousness, convulsion. So all cases of hypoglycemia should be checked. Not only checked, you should give regular IV transfusion of 5% dextrose. And it is the dictum that at least in first 24 hours of malaria when you are treating, you should check blood glucose level every 4 hours. And there are various reasons why hypoglycemia is common. And nowadays you are using artesunate, but only few years back you used to use quinine. Quinine itself is an hyperinsulinic drug which causes hypoglycemia. So my next question to the panelists, what are the other presentations of severe malaria you come across in a child?
Severe anemia is the presentation.
Severe anemia, very good.
You have respiratory distress. Where,
why do you have respiratory distress?
Because of metabolic acidosis most of the time.
Most of them it is metabolic acidosis because the blood circulation is sluggish. There is production of lactic acid which is not being properly drained by the kidneys and the livers, and you start developing Kussmaul's respiration. And once you start developing this air hunger, it is a very dangerous condition. And now coming back to Sahil again, Sahil, now the generalized tonic-clonic convulsion was controlled by midas and glucose. He regained consciousness after 1.5 hours. Now the patient has meningeal signs with intermittent opisthotonus. Should a lumbar puncture routinely done in a complicated malaria with unconsciousness, and what additional information it would give?
So lumbar puncture is very important in cases where you have currently you have other causes also. So you need to do lumbar puncture, but prior to that, if radiological investigations are to be done, it has to be done. Otherwise, HSV or other encephalitis syndrome may be also recognized.
Most experts will do a lumbar puncture unless and until it is contraindicated, because it will exclude the other important causes. So, should a child with severe malaria receive antibiotics? What is the opinion of the house?
Most of the time only 4 to 5% have bacteremia. So you should not miss in a peripheral setup where you don't have diagnosis. You can start. And
so when the culture facilities are not there, it is better to start, because
yes,
they are very prone to gram-negative septicemia. And most of the experts will give antibacterial along with antimalarials, and once the blood culture reports and other reports are negative, then they will stop it. So the patient is being treated with IV artesunate. The patient now has regained appetite, able to swallow after 3 days, no further convulsion, no fever. You don't have oral artesunate these days. So how do you continue antimalarials, and what antimalarials you want to like to give?
So the patient is, for last 3 days, the child is well. So now as per the dose that artesunate and halofentrin, lumefantrine combination can be completed for the 3 days. And beyond that, if the child is well, there is nothing needed.
So once the child is fit enough to swallow and 24 hours of IV antimalarials has given, you switch over to the combination artemisinin combination therapy. In Delhi, your choice of combination will be artemisinin plus sulfadoxin. But in eastern India, in Odisha, Bengal and others, because most of the malaria parasite has already developed resistance to sulfadoxin, we usually continue with artemether lumefantrine.
And another thing is
What
that,
for-
can I just add, because our G6PD deficiency is very high in north, so one has to be a little careful when one is giving.
In case
And
of
that is what,
falciparum
with
malaria-
the experience I would
In
like
case
to
of
say.
falciparum malaria, we don't use primaquine. Primaquine is for Vivax malaria where we give it for 14 days. In falciparum malaria, we give only a single dose of primaquine. So G6PD test is more important if you have a Vivax malaria, not in this case. But still, always it is better to done. Can anybody tell what further advice you have to give before discharging the child?
We have
The-
to complete the whole treatment and in possible to prevent relapse and recurrence, add primaquine. Before that you have to do a G6PD and continue primaquine. It is
The most
falciparum.
important is malaria mosquito starts from dusk to dawn, unlike dengue. So it is very important, you should instruct the parents that the child should not be bitten by the
Mosquito.
mosquitoes. So they should sleep under a impregnated net, insecticide impregnated net, and very careful should be from dusk to dawn. So you have to take care. So coming to my next case, a 8-year-old boy from Bihar during the monsoon had a history of high fever for last 3 days with occasional vomiting. Since morning, the child is drowsy with some abnormal movements of the limbs. He has generalized seizure, following which the child has becoming increasingly drowsy, and he has also started developing posturing. So my question to the panelists, what are you thinking in this case?
In view of the child is drowsy with abnormal movements, it's likely to be a meningoencephalitis and more likely to, because of the arbovirus, and then...
Why, you should
and
also think of cerebral
And let me
malaria
hit
as
the nail on the head, Japanese encephalitis.
See, because he's 8 years old, he has fever
So,
for more than 3 days.
First, cerebral malaria, acute encephalitic syndrome.
AES, that's what I'm coming to.
It can be tuberculous meningitis. So these are the few, if you think of infective causes.
So going with the presentation, the patient from Bihar, 8-year-old. So first it's a syndromic diagnosis. So coming to the mind is that this sort of constellation of presentations is AES, number one.
Acute encephalitic syndrome is the most,
Yes, sir.
and under acute encephalitis syndromes, all the differential diagnosis I have told
Whether
comes
all
under in this.
arboviruses come under that category.
So how do you approach such a case? You should always go for a systemic approach. First, you see the signs and symptoms of the anatomic, that will suggest the anatomical involvement. Next, you see the temporal correlation, when the symptoms have started and when the child come with CNS manifestation. And lastly, your epidemiology, radiology and laboratory tests will define the etiology. Yes. Now, all of you know that every devil has its own den. So, thinking of Japanese encephalitis, where does Japanese encephalitis affect? Is it cortical, deep gray nuclei, cerebellar or Roman encephalon?
So thalamus and deep gray nuclei.
Japanese encephalitis usually deep gray nuclei. They usually affect the thalamus
Yes, sir.
and
Basal ganglia.
basal ganglia and also some nuclei.
Subcortical.
Cranial nerve nuclei. What are the viruses which especially affects the cerebellum? One is chickenpox virus, another is mumps. And what is rhombencephalon? Rhombencephalon is pons and medulla.
Yes.
It is the enterovirus. Enterovirus especially affects the
brainstem mainly in
rhombencephalon. And enterovirus can give rise to very severe consequences. It can give rise to pulmonary edema and the death of the patient. Though enterovirus in our country has not that dangerous, but in China there are reported many deaths. And what about herpes simplex virus? Where does it affect?
So cortex.
Cerebral cortex, especially frontal lobe.
Yes.
Frontal lobe, it causes olfactory, gustatory, disturbance in speech, and also it involves the limbic system. So it causes abnormal behavior. So whenever you come across such a case, First you see the signs and symptoms. This will give an idea where is the anatomical involvement. So now what we have in our case, it's an irritation or inflammation of the grey matter. Is it cortical or deep? What is the anatomical localization? Seizures, abrupt onset, dense encephalopathy with posturing. Is it bilateral diffuse cortical lesion, or is it bilateral basal ganglia or thalamic lesion, or brainstem lesion? Where you think, considering the symptomatology, where is the problem lies?
So is the basal ganglia and thalamic
So
lesion?
it's the answer is deep grey matter nucleate because brainstem lesion with posturing, and these all suggest that it is a grey matter infection. Now coming to the pathological diagnosis, we take a temporal. Hyperacute, if your problem starts within minutes to hours, then what you think? Then it is most
Trauma,
likely
vascular trauma.
ischemic, vasculitis, hemorrhagic vasculitis, trauma or toxin. If it comes within 1 to 7 days, then most likely it is viral, inflammation, metabolic or endocrine. And subacute, the classical example is tuberculosis, enteric encephalopathy, autoimmune malignancy. So two important things you should see. One is signs and symptoms, another is the temporal correlation. And then you go for your investigations and other things. So etiological diagnosis, what we have, it's a basal ganglia or thalamic involvement. It was a rapid progression, relatively preserved markers of inflammation. In our cases, his CRP and other things was not that high.